morning. I am Dr. Wiroon from Khon Kaen. I am proud and feel privileged today to be the moderator of this section, which is the ASEAN perspective for anterior cruciate ligament reconstruction. I think most of the sport medicine surgeons, especially performing knee surgeries, would see the ACL reconstruction like butter and bread. It is everyday work. But anyway, there are still some issues that we have the interest to discuss about, especially from our ASEAN delegates. First of all, my co-moderator is my son, Dr. Pattaya. So, and our participants, we have 4 participants today from Indonesia, which is Dr. Ghuna, Arioharjo, Utoyo, okay? And from Singapore is Dr. Lingaraj Kishna. From Malaysia, for Dr. Seow Hui Teo. And from Philippines, Enrique, Leonardo, C.Pasion, okay? Okay, so welcome everybody. For today, rather special for this kind of discussion. We have rules that everybody should follow. We have 4 topics in this, and with different issues in each topic. Each issue in the topic will be sequentially discussed by the delegates, and you can add rationale or why, if appropriate, for that topic. But you can skip for the concordant opinions with former delegates. And everyone will have about 2 to 3 minutes to discuss about each topic. And then we'll have about 10 minutes left for question and answer at the end. For the first one, the part will announce for this.
Okay, let's start with the first topic about the graft choices and graft fixation and trend toward the future. Okay, we're gonna ask the panelists from the right to left. The question will show in the slide. Okay, so first of all, let's start with Dr. Utoyo first. Okay, for your opinion about the graft choice.
Okay, thank you. So my preferred graft choice is mostly hamstring. So second choice is quadriceps, and third choice is peroneal longus. Or other case you can do neither way if you want to be bigger, but mostly in Indonesia it's a Muslim, so it's not preferable to do the BPTB. So the graft size should have been approximately about 8 millimeter, either single or double. And third graft choice for patient with different activity demanding levels is the same, but now whether you can primarily do the ALL or LET in the primary with the high demanding patient. And graft fixation techniques, usually with the button and screw, and graft choice revisions also we can do as the quadriceps or a peroneus longus, and with or without the ALL or LET, or even correction of the tibia, posterior tibial slope, osteotomy. And alternative graft choice, if short or prevalent one, actually the peroneus longus is to have a good long and big diameter. Yeah. In case to undergo ACL reconstruction in your own knee, would you commit to take the above selection, or rather asking for the different alternative? I think it's different alternative.
So which one do you want to choose? The same IT for your knee or differently?
Hamstring, probably.
Hamstring.
Yes.
Okay. Okay.
Thank you.
Can you hear me? Okay.
Lingaraj,
Thank you.
yes.
Yes. So just to run through the questions. So the first one, my preferred graft choice in most patients is a quadruple semitendinosus. However, in certain patients, I would use a quadriceps tendon. For example, in female athletes, patients who have MCL, concomitant MCL injury, and those with, especially female athletes with valgus knees as well, I would use a quadriceps tendon. Preferred graft size, as Gunnar mentioned, I think most data suggests that 8 millimeters or greater is the preferred choice associated with lower revision rates. I use a single bundle technique. For patients with different activity, so as there's a lot of biomechanical clinical data to support lateral augmentation procedures, I use an LET in patients who are going back to pivoting sport or competitive sport. Fixation technique, I use suspensory on both sides because the graft I get with a quadruple semitendinosus is relatively short. So I use an adjustable loop on the femoral side and I tie it over a button on the tibial side. In revision ACLR, in a younger patient, I would generally use an autograft. So if that patient has had a hamstring previously, then the choice would then be a quad tendon in the revision setting. In an older patient, I would use an allograft. Alternate graft choices, if short, well, I suppose it's one or the other, depending. But the fallback back home is an allograft, because that's available. If I were to undergo ACLR in my own knee, I would follow my own advice. Thank you.
Okay, now it's my turn. So my preferred graft choice is hamstring, yeah. And preferred graft size, I think, is same as everyone. Minimum size 8, and possibly have a bigger size would be better. But again, I think it depends on the size of the knee because sometimes Asian's knee can be small, so we do not want to overstuff the knee with a super huge graft. As for graft choices for patients with different activity demand levels is still the same for me. Graft fixation technique at femoral and tibial, I'll use a suspensory. I've moved forwards towards all inside. Previously, I used to use suspensory and screw fixation at the tibial side, but now I move forward to all inside because I'm sometimes able to save the hamstring. I can just harvest one and I fold it and give me a very good graft size. And I like the tensioning that I get when I do adjustable. For graft choice in revision ACL, well, the easier way out, aerograft. But of course, sometimes we can use a patellar tendon bone. But the problem is, in my population, most of them, they have this prior position. Sometimes they have anterior knee pain, which we need to tell the patients, which is one of the possible things that can happen. As for alternative graft choices, if short or preferred one, well, I still think that either one of those that I've mentioned. And in the case of undergoing ACLR in my own knee, I'll follow the way I do. Yeah.
Yeah, for me, I think it's all hamstrings, preferred graft choice, and preferred graft size. Like everyone said, minimum 8, but I like it more like bigger, 9, 10. But of course, depending on the notch, so you don't want to have any impingement. The size of the notch. Then graft choices of patients. I still prefer hamstrings, unless it's the patients are very big, very strong, athletic. I can actually use also the patellar tendon. Okay, graft fixation. I like suspensory. I've been using all inside technique for more than 5 years now, and I think it's still for me the best. Graft choice in revision ACL. I still prefer the hamstrings. Normally I use the semi-T. With my semi-T, I still get like 9 for average size. And for alternative graft choices, yeah, as I said, I can use the quads. I can also use the patellar tendon. And number 7, if it's my knee, I think I'll just do the same.
I would like to ask Dr. Seow Hui Teo, you prefer the hamstring, okay? In case you have to do the bone patellar graft warm total tendon graft. Are you comfortable with that?
I'm definitely not as comfortable as doing a hamstring, which is what I have been doing all the time. Yeah. But yes, we do. Yeah. Sometimes, but with very rare cases. Yeah.
How many of you that are
Probably I would.
comfortable with bone tendon bone graft? Are you okay?
Yes, I am. I have used bone tendon bone graft in the past, but I've tended to move away from it. I mean, patients, I mean, it's well reported as well. They get quite a lot of needling pain, although it's a good graft to use, no doubt about that. Heals well and clinical results have been good.
How about you?
Me also preferable, but sometimes you have to consent the patient about the after harvesting.
I mean, the
representative.
technique. Are you comfortable with that one?
Yes, yes, of course.
Okay.
Yeah.
How about Pasion?
Yeah, I'm comfortable.
Okay, thank you.
So it looks like the hamstring is the graph the graph that you all of the panelists choose. So what is the reason behind that you use this graph? Believe in its biomechanics, technically is or less donor side mobility. What is the main reason that you all of you choose the same IT?
Okay, for me, it's a simpler technique, less morbidity, and you can achieve by the good rehab to do more strength of the hamstring to back to the previous level. And yeah, I think it's about that.
Religious region?
Sorry.
Religion.
Revision.
Religious.
Oh, no.
Religious?
No.
No.
No. Okay.
So what do you think about the substitute quad? Do you think because it's the substitute technique either? So do you think the substitute quad, when compared with the same IT, do you think are there any different in your idea?
I think certainly if you look at the literature, there is an increasing trend towards the use of quad tendon nowadays. That's probably due to the fact that we have better fixation implants available for the quad tendon nowadays. And I think in certain patients, so biomechanically, the advantage would be that you get a more consistent graft size, whereas there's a lot more variability in hamstring graft diameter in patients, particularly in Asian patients. And also in certain subgroup of patients, say, who need their hamstrings, whether they're females who have generally weaker hamstrings, as well as sprinters who need their hamstrings, and the quads then becomes a good option.
Okay, let's turn to the next topic. So the internal breast augmentation. Okay. This Dr.
Okay, for the first, routinely used for selective cases, I do the internal brace in selective cases, mostly if it high demand on and the Baton score and high level of Baton score. A good candidate for internal brace augmentation, yeah, I thought this first statement is already answered. Tension setting for internal brace, try not to do more tensioning on the internal brace rather than on the graft. And rehabilitation, I think it's almost the same with the non of the internal brace case. In case to undergo ACLR reconstruction in your own knee, would you prefer to add internal brace? I think it depends on whether I don't have any laxity or something like that, so I don't need any internal brace. Thank you.
I think I would start with, so what does the literature say? I think there's a lot of good biomechanical data, although there's not much clinical data. Having said that, do I routinely use internal brace? Yes, I do, in all my ACL patients. So good candidate doesn't, I guess because I use in all patients, it doesn't apply. Tension setting, it should be tension separately from the ACL graft. And in terms of rehab protocol, there is no difference. And if I were to undergo an ACLR in my own knee, I would prefer to use an internal brace.
Okay, for me, I don't use internal brace. So probably all the rest of the questions I'm not able to answer. I'm still quite curious about the long-term outcome for using an internal brace. The reason why I don't use is I'm more concerned of the incorporations of the internal brace in the long term. Yeah, will it cause any shearing effect on the ligamentizations of the graft? So that's the reason why I don't really use it. Otherwise, I think it's a very good options for, I think some of them even reported early rehabilitations where you can go back earlier. But myself, I'm still waiting.
Yeah, for me, I don't use it routinely. So I choose my patients, whether they're really high professional athletes, collegiate athletes. I use them especially for partial tears. Okay, especially also if your graph is not adequate, you can actually use that. Tension setting, of course, it's independent on the ACL if you're going to do an ACLR. And rehab, I think it's almost the same. And if it's for me, well, I think I don't need the augmentation if you're going to do my ACL, especially my friend who's going to do it is very confident with this technique and also the graft.
So, what is your intraoperative technique to set the tension of the internal brace? Do you have your like a technique?
Well, normally it's independent, so you don't incorporate it with the ACL. So it's like using it with the PCL. Okay, you put your fixation first for the ACL, then that's when you actually put your fixation for the augmentation. So this one is just really just for support, because if it's too tight, there's going to be problems in the extension and also the movements. So all you want to do is actually make the graft heal first, and your augmentation is for protection.
So how do you determine the tension that is not over tight or too loose?
Well, the proper tensioning is actually first putting the ACLR. So you also put it like further down. Okay, so in that way you can see tension is not too tight compared to the ACLR. So at least it's there to protect it. And for me, also for the rehab, I think the rehab is very good. It has to be very good, like the physiotherapy, the strengthening, conditioning. So at least it's going to help everything for proper functional movements. Especially if you're going to treat the athletes, make them go back to play properly.
Dr. Utoyo, you say the rehabilitation program are the same as without bracing, okay? So what's the benefit that is added by the bracing?
So my opinion is that how you make the graft looks like the antithesis of the. You see, if you had a hamstring, that's a different antithesis with the patellar tendon. So avoiding, I'm using the patellar tendon. Then sometimes I use the hamstring with the internal brace. So for the tensioning, also in the rehab, and the rehab is the same with the patient without the internal brace, but in tensioning you have to do both in the same time. You do the tensioning, not in the separate. Okay.
Any different ideas?
So you asked about the rationale for using internal brace. So my rationale is to reduce the risk of progressive graft laxity, particularly in hamstring tendons. I think that's a concern. And it's shown that hamstring tendons tend to have greater laxity compared to, say, a PTB in some studies. So, as I said, there's biomechanical evidence to show that the internal brace improves the stiffness of the construct. But whether it makes a difference in the long term, I think we don't have that much data yet.
Okay, let's move on to the next topic: lateral extra-articular tenodesis, or anterolateral ligament reconstruction in ACL reconstruction.
So routinely, no, I do the LET or ALL in selective cases. If required LET or ALL, I prefer an LET. Good candidate for LET, I'm trying to move from the revision to the primary. So if it revision, so usually with considering of the LET. Tensioning setting for LET, knee position is about 20 or 30 degree flexion. Rehab oscillator with it almost the same, and trench tower to feature in the primary. So I agree with the if the trend is using. So some says there is two fixation or two stronger is better.
I use the LET in selected cases. So I'll go straight to question 3. Good candidates. I tend to follow the indications laid out in the stability trial. So that would be patients who are 14 to 25 and who have 2 of the following indications. So return to high-level competitive sport, high-grade pivot, generalized ligamentous laxity. So the other indication that I use sometimes is, although it's not from the stability trial, it's from the Santi group, it's if they have a medial meniscus tear, I would add on an LET as well. Tension setting, so I think it was discussed yesterday, I follow what was discussed, 30 degrees neutral rotation, 20 newtons of tension. Rehab remains, it's the same. Trend towards the future, I think that, I believe in lateral augmentation procedures, and I think that in the future what will happen is that the indications will be further refined and further clarified, and I think that a larger proportion of patients would be found to benefit from such a procedure.
I think we have said all this, but probably I'll just go through it again. Routinely used, no, is for selective cases. So I'll go through that later. And if required, is it a LET or ALL? To be honest, I've been doing ALL before this, but I shift toward LET now because I thought of the added benefit of tightening the lateral capsule that might have been stretched during the injury. And good candidates for lateral tenodesis is like what we've gone through, but I would say majority of my practice for primary cases, there are those patients with hyperlaxity. I found out that in my population in Malaysia, it's around 20% of patients have hyperlaxity, and also sometimes patients with recurvatum. And I'm moving towards more for high contact sports, athletic young patients. And in terms of high pivot shift, sometimes I have patients with high pivot shift, but I don't really do a LAT, but I need to check the MRI to see whether is it because of any lateral root tear that can actually give you a high pivot shift as well. And for tensioning setting, I think we've gone through it just now. So for LET, that is actually doesn't really matter where you position the knee, but tension has to be less than 20 newtons for both. Rehabilitation, same as ACL. And trends towards the future, yes, definitely I can see there's a possible future for doing more LET and ALL. And of course, one more thing that I forgot to mention is for revision cases. After ruling out all the possible failure, we need to probably think of doing a ALL or LET. Thank you.
Yeah, I don't routinely do it. I don't use it for selective cases. Okay, normally for all my cases, I check the rotational instability after I do my surgery. I like LET more. I don't really believe on ALL. And for good candidates, actually Teo had a very good discussion, at least a lecture yesterday about this. Candidates, recurvatum, high impact sports, revision cases, girls less than 20 because they're very hyperelastic. And yeah, I think it's those. Tension setting, well, place it in 30 degrees. And you don't want it too tight because it will actually affect the biomechanics of the knee. Rehabs, I think, still the same. And I think depends also the type of patients you have. Like for Andy Williams, all his patients are all athletes and soccer players. He does it all 100%. So like I think for Asians, very, very small population that you really have to do an LET. And there's, I also read this, I saw a literature that if your size is like 9 to 10 they compared it with using an LET with a size less than 8, the results are just the same. So I think there are trends toward future primary. Well, I think, as I said, it depends on the patient population you have.
So I have one more question for you. In the revision case with the lateral compartment osteoarthritis, just like a mild to moderate, do you still do the ALL or LET in your patient? In the revision setting?
Well, it depends if there's really rotational, but of course, there's already osteoarthritis. You have to be careful because if you tighten it too much, you'll have to make it worse.
So what about the others?
Yeah, same opinion. Because to begin with, I really want to find out why the patient has a re-rupture or failure of the primary surgery. If it's really due to, if I rule out all technical issues, and yeah, I think I will still do a LET for the patients. But again, something I'm also concerned of is any patient with valgus knee. So there are the cases that I may be more careful for LET. Yeah.
Dr. Krishna?
I do LET in all my revision cases, but the interesting question that you raised, I suppose the concern is to do with the traditional concern about lateral compartment overload with an LET. I think more recently, there was a paper yesterday that was presented which showed that if you tension it at in neutral rotation, then you don't increase the risk of overload. Yes.
Yeah, almost the same, I think. But mostly in the revision, I need to see the mechanical axis of the patient, right? Whether you have to correct also the plateau or the tibial slope in the revision cases. Thank you.
A brief question. What is the major difference between LET and ALR? What's the major difference, do you think? Or the same?
I think biomechanics studies show that's almost similar, but the difference is one is anatomical, the other is not so anatomical. But again, when we look at ALL, it's a very thin strip of tissue, so I think it doesn't really make any big difference to it. Yeah, I don't know about
You don't
the
believe
other.
in?
No, I do believe that there's a contributions to it. That's why I'm doing it. Yeah, if not, yeah. But we doesn't really need to reconstruct exactly at where the anatomical site is, because it's just a very thin strip and it's like attached to all the way up to the fascia lata.
One brief question. If in case you do the double bundle, is a reconstruction, do you think ALL or LET still is beneficial?
Well, studies have shown that doing an LET additional, it actually really helps. Not much, but at least it lessens the risk of re-injury. Yeah.
The last.
Okay, the aging concern about the ACLR, okay?
So maximal age of the ACLR reconstruction still beneficial. Yes, so actually I got a patient with 57 or 63. Still, as long as the patient got still nothing problem with the mechanical axis, varus knee or not maybe mild arthritis, you can do ACL as long as he's in good health and good BMI, body mass index, and are not overweight. Main reason of that is not indicated in active elderly. Of course, it's already got high grade in osteoarthritis and quite varus or a deformity on the knee. Any age sustaining ACL deficiency associated with mild or moderate osteoarthritis? Yes. Okay. Any age sustaining? Yeah, maybe 40, 50 years old. Could ACL prevent progressive OA? My opinion, yes. Even though actually you have to observe the progression of the OA. Preferred technique to perform ACL in the condition? Not much, but still considering about the axis for me, mechanical axis.
I guess age is a number. I don't think there's a maximal age, and I think there are several papers that have shown good results even in patients who are above 50 undergoing ACL reconstruction. So main reasons why an ACLR is not indicated. So in an, I wouldn't say elderly, I say an older patient who has an isolated ACL injury and they have a trial of rehabilitation, and if it is successful and they have no instability symptoms, then clearly they don't need an ACL reconstruction. If they have established osteoarthritis, I would probably not do an ACL reconstruction. Any age sustaining ACL deficiency associated with mild moderate OA. Could ACLR prevent progression? That's controversial. I don't think there's not a lot of evidence for that. Preferred technique for using ACLR in this condition. So I think they've also shown, in patients who have established medial compartment OA and ACL deficiency, then in these patients, they would benefit from a concomitant ACL reconstruction and a high tibial osteotomy. So that would be the option in those patients.
Maximum age that ACLR is still beneficial. No maximum age, as we have discussed this. Main reason that ACLR is not indicated. So I think for me, the most important is where I talk to my patients, I take a good history. I want to find out whether this patient is having instability more or pain, because I'm sure this patient will be having both pain and instability. So, and I have to tell them, if I were to do an ACLR for you, you can have probably a more stable knee, but the pain may not be able to take away. So if the patient understands that, and if it's the instability that is really disturbing the patient, since he's having a very active life, then I'll go ahead with the ACLR. Any age, could ACLR prevent progression? Not sure about that. I guess so, because with a stable knee, definitely it reduces biomechanic loading to the knee joint. Definitely any stability can reduce the progression of OA. And preferred technique would be the same as what I've discussed.
Yeah, maximal age, there's no maximal age for ACLR. Yeah, I actually have a patient, like a 60-year-old, but he's a laborer, still works very hard, carries heavy stuff. So, and no very minimal OA, signs of OA. Yeah, we did it after 1 week, 2 weeks. That's why he's very tedious with this physiotherapy. 1 week, he's walking fine already. Range of motion is very good. So it depends on the patient also. So maybe you have to choose the patients you select. Okay, if they're so you have to give them the correct mindset. Okay, you have to tell them before and after what will happen, and of course the surgery is easy. The battle's really after the surgery, which it's on their part. Yeah. So main reasons not to, like what Theo said, yeah, most of them, if they're active elderly, it's mostly pain. So you really have to really find out which is it really pain or instability. Yeah. Any age, ACL, yeah, of course, doing the ACL will always prevent, not really prevent, but maybe lessens the risk of progression fast. The OA preferred technique, like I think what we all said earlier.
So the reverse question for me, what is your minimum age?
Well, my eldest patient was a 60-year-old laborer, and he really has to work because he's the breadwinner of the family. And that's his life, because if he stops work, they won't eat.
For in case of the elderly patient with interior cruciate ligament deficiency and also with various deformity, what would you do?
Elderly or,
Elderly patient, say 50 years or more.
well, if it's really like a grade 3, grade 4 OA already, I don't think, because if you're just going to do a total knee,
No OA, supposedly.
no OA,
But the
Just a
deformity is a various one.
varus. Well, I think HT was actually good for that. Do a osteotomy.
That's it.
Correct the alignment.
So what is your minimum age to do? Like, for example, if your child, just for example, 15 years old and got the ACL injury, do you still wait until the fight is closed, or you gonna undergo the ACLR?
Well, studies have shown that kids, or depends on the age and their activity, because when they're kids, they really do anything. They run, they jump, they won't even listen to you. And the progression of having damaging the cartilage, the meniscus is very high if you don't do it. So for me, for 15-year-old athlete, they really play. Yeah, I'll do it.
Do you think the tibial tunnel for the adolescents before the fight is closed, there is some harmful effect to the growth? Do you think? This one.
Okay. For me, it depends on the age and depends on the demand or the activity, and also you can choose either the physical sparing technique or others. And some said there is not so many difference between if you puncture or you put the tunnel in the physical plates.
I don't treat very young patients. All my patients are over 16. So I am in those patients, they're usually, the physis is closed or it's almost closed. So I would just do an ACL reconstruction the normal way.
For me, again, I think depends on the populations or the activity level, because like what you say, most of the child, they're okay. They're quite active. They don't really listen to any conservative treatment that you want to prescribe for them. But again, I think studies show that there's not much of a difference by doing by drilling through the tibial. But again, with newer techniques, I think with an all-inside technique, I don't really need to run through the physical plate. Is quite a good choice. But if you ask me, if it's me, I would probably wait because I don't want to take the risk of even 1%. Yeah. But again, depends, because if it is a active child then and who is involved in any sports participations, yes, I think you should go for a surgery. Yeah.
So because we still have a time, so what do you think is the perfect timing to do the ACL reconstruction? Immediately after injury, a month, 2 months, or 3?
Well, for all my patients, I'd make sure that the knees settle down. Patient's ambulatory, good range of motion, no more swelling. That's when I actually do it, because no rush anyways.
Okay, in terms of timing for ACLR, yes, a good range of motion, not much of effusion, and not much of inflammatory changes. In terms of time, how long to wait, I would not define how the shortest duration, but I would say not more than 6 months, because we know that there will be a lot of further changes or more further damage to the knee, meniscus, cartilage. We will wait more than that. And as we know now, there's more of upcoming ACL repair. So I think I will also counsel my patients the possibility of doing an ACL repair, But again, it's something that we need to talk to the patient. They may need to have a reconstruction later on if it fails. But it's one of the options that's probably available that we can think of to do early repair. Yeah.
So I agree. I think there's good data to show that early ACL reconstructions, even if done within 3 weeks of injury, show good results. But I think the key issue is whether the patient has a normal gait, good range of motion, and reduced swelling. And I think if they do, then they will do well after early ACL reconstruction.
Yeah, I also agree. For early, I used to wait within 3 weeks. Within 3 weeks, and for late, not more than 3 or 6 months. So considering of the concomitant other injury about the meniscus and cartilage, and also in early setting, we need to make the knees settle down for the swelling and reduce the cascade of inflammatory.
What will happen if you do the immediate ACLR after the acute injury?
When in acute, you will save the atrophy of the muscle, right? But some said you will increase the cascade of arthrofibrosis. But and also if you do early, then you also have to make homework for reducing the arthrofibrosis, but you save the atrophy of the muscle. Even if it's late, usually if the patient came late with the atrophy of the quadriceps, but have good in range of motion.
So for the post-op rehabilitation, any one of you use the knee brace after the surgery, always, or in selective case?
Well, I always start my patients with the knee immobilizer just for 2 to 3 days, just to make it settle down. Because I've seen patients, first day they try to stand and walk, they slip on a wet floor. So of course that will aggravate whatever you did, right? So it will swell up, inflame more. So just for 2-3 days, I just put that. After that, I take it out.
I still protect my ACL, but most of the time my patients have a concomitant meniscus tear as well, so meniscus repair. But even if an isolated ACL, I know we don't really need a brace, but actually I still put on a brace for my patient because, like what you say, sometimes they are not careful. It's more of like a protection mechanism rather than any functions that it serves. Yeah. But for me, I think the post-op rehab, very important to have a good knee extension in the first 2 weeks at least. You need to have that. Yeah.
Yes, I also immobilize them for a short period of time, for a week. There was an interesting study that came out in JBJS a year or two ago, which was an animal study which looked at ACL reconstruction, I think in a rat model, and it showed that a short period of immobilization actually led to better integration of the graft within the bone tunnels.
Some technical perspective about the making the tunnel for the femur. Do you use transtibial or transportal, or why?
Me, I use transporter because you can aim more easily rather than the transtibial tunnel. So you make it more anatomical for the femoral tunnel.
Yes, I agree. Transportal, I think it allows for better control of femoral tunnel position. But I think one needs to be aware of the risks as well. Damage to the medial femoral condyle as you come in, shorter tunnel. But yes, I think, I mean, personally, I use the transporter.
Yeah, same opinion, but I also use transportal, and I also now use outside in technique, so that reduce the risk of any damaging to the condyle.
Yeah, definitely transportal. Yeah, all inside, the more anatomic, better location of your tunnels.
So what about because some of you use the interference screw to fix the graft at the tibia, right? In case of you use the interference screw, you also adjunct with the suture to the post or just screw?
Me, well, I don't like using screws anymore for the past more than 6 years. So
So I still do sometimes because, but I don't put a post. Yeah, I just put a screw.
I don't use screws. I use suspensory fixation.
I'm not routinely used to post.
Okay. So for the post-op, do you still put the drain in or not use the drain anymore right now? The drain.
no, I don't use drains.
Yeah, I don't use drain too.
I use drain.
Okay.
Why?
50,
Okay.
50.
First, I use drain, and then I'm not using any drain, and now I'm changing again to use drain. It's because to remove all the extra fluid earlier rather than you late or came with the clinic with still an effusion, something like that. So now I use the drain again.
Why don't you use drain? Do you need to aspirate the knee later?
No, so far I rarely need to aspirate the knee. Well, maybe I can go back and try putting a drain to see any difference to my patient because I think it makes a most difference when you see your own patient. Try both ways and see what's best.
Okay.
I just want to add, I don't use a drain, but there's several papers that have come up recently which have shown the usefulness of you giving tranexamic acid perioperatively. So that's been shown to reduce swelling and bleeding post-op.
So in your experience, have you ever used the transom? You put it inside the joint or
Systemically, so it's given at the
systemic,
junction.
right? Okay. So for the post-op pain, have you ever used like a knee cocktail, like in the total knee arthroplasty? In your
Well, I normally use Naropin. It's a ropivacaine. Yeah, it helps for the pain control. But of course, I always tell my anesthesiologist to do a block. Actually helps for pain control. Yeah, I don't like using bupivacaine because there were studies when I was in Australia. There was a study then comparing ropivacaine, bupivacaine. Bupivacaine can cause 25% osteochondrolysis compared to ropivacaine, which hardly none.
Oh no, I don't use any cocktail, but yeah, again, my NS will give a block. Yeah.
So I do local infiltration. I don't use a block for my cases. Yeah.
Same. No, I agree with the block.
Okay, I think now we have discussed quite many issues about. Now we'll open the floor for any questions from the audience, please. Or would you like to add your perspective in the very common anterior cruciate ligament reconstruction?
Maybe I can ask questions.
Yeah.
When do you clear your patient to go back to play? Yeah.
I think that's a very, very good question. Can you hear me? So I think there are three aspects to that. I think it's time, clinical, and physical. I think that time is, minimum 9 months or longer after surgery. Clinical is the absence of pain, no effusion in the knee, and no knee symptoms. And the physical is passing, the various tests that have been shown to if a study's shown that if they pass these tests, the risk of injury is lower, and also a limb symmetry index of at least 90% or greater.
Any questions? If really no questions, we'll close this section. Thank you very much for the audience and also for the participants. Thank you.